Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, and today we are diving into a fascinating multi-specialty discussion in an episode titled Cracking the Code, a Rheum-Derm-Neuro Multispecialty Case Approach to Myositis. As we all know, myositis is a very complex and often evolving disease that can present across multiple organ systems, making collaboration between specialists essential for timely diagnosis, accurate assessment, and optimal management. In this episode, we'll walk through a real-world case-based discussion exploring the overlapping rheumatologic, dermatologic, and neurologic manifestations of myositis while highlighting how multidisciplinary care can improve patient outcomes. Joining me today are two outstanding experts bringing unique specialty perspectives to this conversation. First, we're joined by Laura Bush, an experienced dermatology clinician, and we're also joined by Maggie Naclerio, a neurology specialist. Laura and Maggie, welcome to RhAPPcast. Before we jump into today's discussion, I'd love for you to introduce yourselves and tell our listeners a little bit of background and tell us about yourself, where you practice, what you do. We're just so honored to have you here.
So hi, I'm Laura Bush. I guess I'll go first. And I practice in Fayetteville, Georgia, in a private practice. I see mostly medically complex dermatologic cases. I do some surgery. I've been a PA for 35 years with the last 23 in dermatology. And I truly love this specialty. And I love to interact cross specialty because I think there's so many times in treating patients that we need to reach out to our colleagues in a different specialty because the disease processes cross over and we can take better care.
Hi, everybody. My name is Maggie. I'm a physician assistant in neuromuscular medicine, part of the Department of Neurology at Mass General Brigham here in Boston. I've been a PA for 7 years and in neuromuscular medicine for 6 years. I'm very passionate about neurology education, particularly in the neuromuscular space, and very excited to collaborate as I do every day with my clinician colleagues here at Mass General Brigham.
Wow, this is so incredible to have both of you on today. I couldn't be more excited to have you. So let's go ahead and just jump right in. We know patients with myositis can present very differently depending on what specialty they land in first. Laura, can you talk to me about a memorable presentation that made you first suspect inflammatory myopathy?
So yes, I have a couple cases, but probably the most recent was and the most tragic. The patient came in with a rash. She was skin of color, so it was very difficult, but she had some other symptoms. She had somewhat of a holster sign, which is kind of along the lateral thigh area. She had a rash on her chest, not in your typical, I would say, presentation, but it was kind of burned out like it had been there a while. And she also had some duskiness around her eyes, also very difficult to see because of her skin of color. But what bothered me about this woman is that she was having a little bit of hoarseness, and I did the workup, and she ended up being positive. So I think there's those little clues. We look for the Gotrin's papules on the knuckles. There's little things that we pick up, and often they probably went overlooked in this woman because she didn't make it to me until the very end. So,
I think that highlights, how important it is, especially, and I think APPs actually do this very well. I think we don't want to miss anything. We're often overly thorough. I tell all my patients that, I don't want to miss something. And so, if I order perhaps more tests than you've had, it's just for that reason. But that's sad that this person, was very, very sick by the time that, she got to you. Maggie, do you have a case?
I will say a fair amount of my myositis consults end up coming as hospital discharges to my clinic. So patients often present to the emergency room with weakness or loss of mobility, multiple falls, or sometimes they even present from their PCP offices to the emergency room because the PCP or other provider found their CK was elevated super, super high. So I had a case once that I actually saw in the hospital first. She had presented after multiple falls at home, and again, very elevated CK with her PCP office. And so she was directly admitted to the hospital. We were really trying to decide whether she had a statin induced myopathy, so a toxic myopathy from the statin itself, or if this was something else. In that case, she was very weak in a limb girdle pattern of weakness, so proximal arms, proximal legs. She was discharged home off the statin with the expectation that if this was a statin-induced myopathy, that she would get better. And when I saw her in my clinic about 4 weeks later, she was not better. In fact, she was actually worse. And so we decided this was not a toxic myopathy. We ran a bunch of autoimmune antibodies for myositis, and she actually did end up having positive HMGCR antibodies. So we diagnosed her with an immune-mediated necrotizing myopathy and put her on treatment. And I actually just saw her 2 weeks ago after she's been on IVIG for almost 2 years now, and she has regained a lot of function.
So a good story. So we have one that's more tragic, and then one that's actually doing really well. And again, I've seen also the same gamut of when you see people and they're really, really sick. And then of course, you have the malignancy scenario as well that plays into it. And it's interesting, Maggie, something that you said was the patient presented with multiple falls. And I think what that highlights is that not every patient just presents with this classic, proximal weakness. So, I mean, you mentioned that patient, but have you seen any other cases where it was subtle or atypical that was particularly challenging for you to recognize?
Yeah, I think challenging for me, but also challenging for the patient to recognize. I think it's very difficult for patients to communicate what weakness means. And this is independent of pain. Myositis in general should not necessarily be a painful condition. It's a loss of function. And so it's very challenging for patients to say, I'm weak here. What I usually get is, I used to be able to climb the stairs and now I can't. Or I used to be able to grip my coffee cup and now I can't. And so really getting into the weeds during the history, I think, is really important to ask patients, what weakness and what disability mean to them. In terms of atypical patterns of weakness, there are a couple there's one myositis in general that can present with an atypical pattern of weakness, and that's inclusion body myositis, which is actually the most common acquired muscle disease in adults. This presents with a very slow, insidious pattern of weakness that primarily affects the distal arms, primarily the flexor compartment of the forearms. So finger flexion and wrist flexion are very much affected first. And in the legs, it's a lot of weakness in the quads. And what's also atypical about this pattern is it can actually start asymmetrically, which is very different from other myositis, which are typically symmetric. So that can be not overtly apparent and may require further workup, including things like EMG and muscle biopsy, in addition to the antibody testing.
That's super helpful. I listened to a presentation at RhAPP a couple of years ago, and then I convinced myself I have totally missed inclusion body myositis myself. And so it helped me to really think about that when I'm talking to a patient with kind of just more, maybe not quite as, to your point, not symmetric, or it just not, maybe more insidious and things like that, where it just didn't quite add up to me. Laura, do you have anything to add to that?
Yeah, when you were talking, Maggie, I was thinking about how sometimes, and especially in derm, because we're very fast paced, it's what are the right questions to ask when you're asking someone, the weakness. So typically, what I used to test, I'd say, grab my hands and don't drop me, right? When we test for weakness. But I think they're more subtle, like, do you have trouble getting up from a chair? Of course, some of the patients I see have multiple comorbidities. So sometimes it's hard for them to know that's a problem, right? I think it's a daunting task to try to get the right questions to ask. I think it might be more of that, could you used to do this and now you can't condition that we ask patients. Because I think especially in derm, sometimes they don't even know, nobody's putting the piece together. Their primary care is not saying, well, I could send them to derm to get this part and I could send them to pulmonary to get nobody's coordinating that. They're sitting in silos. And that's a particular problem for some of these disease states. Like my particular patient was positive for MDA5, which goes along with the interstitial lung disease. And but nobody put those pieces together until it was kind of unfortunately too late.
That is so sad, and as we know, MDA5 patients progress very rapidly and have such a high mortality, and that is, all when you see the MDA5s, you think, "Oh my gosh, we need to get on treatment ASAP." So I'm super interested in how each of you will take this next question because in rheumatology, we love labs. We love to order lots and lots and lots of labs. But Laura, so when you suspect myositis in your clinic, you're seeing some of those classic skin manifestations, the Gottron's papules, the Schall sign, etc. What does your initial workup look like, and how does that maybe differ than what we do in rheumatology?
Well, I don't know what you do in rheumatology, but I'll tell you what I would do. So I would do a myositis profile, which can only be done at one lab. For some reason, one of the major labs doesn't do this particular profile. And I would also I usually do an ANA with reflex, and I also do a routine labs like a CBC and a comp because I want to know if something else is awry, right? Maybe a urine if they're older and I wanna make sure they don't have an infection on top of something or whatnot. But that's kinda where I don't really get it depends on how if there's a degree of inflammation, I might do like a sed rate or a CRP, but generally speaking, I start there because what happens in derm is when I order labs and if I, just blast labs, usually I don't do that because I leave that to rheum or another specialty, but often I get kicked back and then they can't get covered. So I do what I think I can get.
Absolutely. Maggie, I'm really interested in your take on this.
Yeah. So, in my typical patient with the limb girdle pattern of weakness, who I'm concerned for myositis, my typical workup is a creatine kinase, aldolase, hepatic function panel, ESR, CRP, and thyroid stimulating hormone like a thyroid screen. Otherwise, I let most of the clinical history kind of guide my workup for autoimmune markers. I do a quick review of systems for things like dry eyes, dry mouth, which can present with Sjogren's syndrome. Inclusion body myositis actually has a pretty heavy overlap with Sjogren's syndrome, so that's certainly on my differential. With regards to the hepatic function panel, acute or chronic muscle necrosis can cause transaminitis, so elevated ALT and AST, but without an elevation of bilirubin. If I am concerned about a concomitant liver disease that might be driving up ALT and AST, in addition to the CK, I will also order a GGT, gamma glutamyl transferase, and that can really tell me if that is a hepatic origin for the ALT and AST elevation compared to a muscle origin. So that's kind of like a nice, like easy tip and trick, especially on the inpatient side when we're working up myositis in the acute setting. Of course, there's all this variety of myositis specific antibody tests that we can order. I'm very choosy about how and when to order those. I usually don't order them until I get the CK and aldolase back. So I can really get an idea of like what the CK is at baseline, and then I'll order from there. And again, based off of the other symptoms they have, if they have the skin manifestations, maybe I'm a little bit more willing to order that early on compared to later.
Super interesting. Well, and as we all know, I mean, myositis specific antibodies have really changed how we think about these diseases. I mean, when I first started, I wasn't really ordering myositis, panels. It can be really daunting, not really sometimes straightforward. So, Maggie, what are you doing? How are you, kind of interpreting these? How do you incorporate it? Talk to me about your process when you do decide to order it.
I interpret them very carefully. I think it's really important to look at the entire clinical picture. It is not uncommon for us to get false positives on these tests or low titer positives that we then have to exonerate. In fact, some of the referrals that come into my clinic for myositis are for positive antibody tests with no sign of clinical weakness. This requires us to rely on the CK trending, EMG, muscle biopsy, and our own clinical exam and clinical acumen to say what is relevant. This can be incredibly challenging in these antibodies that can be associated with underlying cancer, like the TIF1 gamma antibody and also the idiopathic pulmonary fibrosis with the MDA5. We can also get false negatives on antibody testing. So the antibody test for inclusion body myositis called NT5C1A has shown to have a sensitivity as low as 36% and as high as 76%. So there's a fair number of patients who actually end up having inclusion body myositis where that antibody is negative. And they do require, the diagnosis purely based on muscle biopsy at that point.
Laura, do you do anything different when you're kind of thinking about ordering this panel?
I probably would call Maggie. No, I probably would call her. So when we're in the skin business, I do usually, if I'm going to order the panel, I order the myositis panel and I use that as a jumping off point, but I don't tend to order things that I can't interpret. So like, that's why, I try to stay somewhat in my lane. So I see the physical, signs and symptoms, and then I might order the myositis, and then I might, coordinate that with their primary care and whatever specialty. Like in the case of the MDA5, I got pulmonary online. I started ordering the CT of the chest. I got the primary involved like immediately, and I didn't further work it up. I just kind of like got everybody that's a player involved. So, as far as doing, I always say with Rheum too, I'll do the start workup if I can't get them in, but generally I'll consult them because it's not something I do all the time. It's a very rare condition. So we don't see it that often, or at least there's probably cases that it is minor and it's just not being picked up because it's subtle at that point. I would imagine the particular patient that I was talking about had gone to multiple people, and she had just kind of gotten, either they didn't see it because it can be challenging in skin of color to see the heliotrope rash. And I think maybe somebody just chalked it up to puffiness. She had a little bit of heart failure, and maybe that was kind of just hiding it, masking it. But yeah, generally speaking, I usually stick in my lane.
Totally. And I would agree with kind of both of you. I think it's important that we, be thoughtful when we're ordering these studies, because then we do have to interpret them. And, also, Meg, you mentioned something about kind of the false positive. I think I love when we do these podcasts where we can kind of give these clinical pearls, because I think that's important, because sometimes patients will present and maybe they have a history of CVID and they are already on IVIG, or, I had a patient with myasthenia gravis who is on IVIG, and a myositis panel was ordered because she had, this terrible skin stuff. And it was very hard to interpret because IVIG will cause you to produce antibodies. And so, she was MDA5. And so I thought, oh my gosh, she's got ILD. Oh my, and then I sent her down to the ILD clinic and they rechecked and it was negative. And so I think, you have to really think about the patient in front of you, and does it make sense? And if it doesn't, you really have to kind of think about, okay, what else can I order? How can I firm up my diagnosis, which is really going to lead me to my next question, which is a muscle biopsy. Oftentimes we think of this as somewhat the gold standard for us when we're really trying to figure out what's going on. Obviously, things can alter this if they're already on steroids, etc. But Maggie, like, how do you find the pathology to help clarify difficult cases in your practice? Or does it?
It definitely can. My long answer is, when it comes to muscle diseases in general, we break our disease states down into two categories: inherited or genetic, and acquired, like myositis. Aside from inclusion body myositis, most all acquired myopathies will present with that limb girdle pattern of weakness. And so any deviation from that would require further testing, thinking about inherited in the back of our minds. And if a patient has that limb girdle pattern of weakness and, we do a CK and it's very high, we can see that in muscular dystrophy just as much as we can see that in myositis. And so in some of these cases, we do rely on the muscle biopsy to tell us the difference. I will say when it comes to inherited myopathy, if there is any suspicion for an underlying genetic cause for the symptoms, we always try to do genetic testing before the muscle biopsy. It's just more diagnostically elegant with the technology and knowledge base that we have today about the human genome, and it's less invasive for the patient. I will say when choosing a biopsy target, it really does, in my opinion, take a physician. One of my physician colleagues does all of our muscle biopsies. I usually have him lay eyes on the patient to choose a biopsy target. Sometimes we'll use EMG to choose a biopsy target. We really want to pick a muscle that is going to be mildly weak. If we pick the weakest muscle to biopsy, it's really only going to show end-stage muscle damage, so atrophy and fibrotic tissue, rather than actually showing us the true pathological disease process going on. We try to pick a muscle that we biopsy frequently, so we know what the true normal is on the histopathology.
That's super interesting, and I think a really valuable, tool that you don't want the absolute weakest area, which I didn't really know that until right now. So that's super helpful. In my clinic, we also will do MRIs. And so, I'll do an MRI of the thighs because I'm trying to look for that area of inflammation that can help potentially target a biopsy. Or, again, save patients to your point, like, maybe there's really nothing there and I'd be less likely possibly to order a biopsy. I guess that's in a patient that maybe has negative antibodies, and I'm really just trying to search for what is going on. Laura, you really kind of highlighted this right at the beginning, but diagnostic delays in myositis are so common. Where do you think patients are losing the most time in their diagnostic journey?
I think that the problem with healthcare now is everything's so siloed, and sometimes getting into derm could have been the answer in this patient, right? It could have been the answer maybe a year earlier or 6 months earlier, but the referral wasn't done. She didn't get into the clinic. And the other thing is that one hand doesn't know what the other hand's doing. So it's so hard. In my area, it's so hard even to get into a primary care until something's like tragic and then everybody jumps to see it, right? So I think one of the things that I personally do, to my point of like not wanting to step out of my lane, sometimes I make sure that colleagues in my area that crossover specialties, for instance, rheumatology, that I have his phone number and he has mine and we share patients or ID or whichever, and that I reach out to that person and coordinate it. And I have an open door for other specialties. If they call me or text me and they need to get somebody in, I will get them in. Provider to provider would help a lot. The other thing is that some of these signs are subtle, right? So putting them on everybody's radar, because when you don't, we were talking about rare diseases earlier today with a colleague, and it was, these things don't pop up all the time for us, right? So, but do they? Are the subtle signs there? And just keeping it fresh to mind, like what is the Shaw sign? How can you just grab somebody's hand to hold their hand, but looking at their nail capillaries or on their nail bed? If you look at, for instance, in my field, if it looks like eyelid dermatitis, is it really a heliotrope rash? Are you actually letting that thought go through your head and keeping that on your radar? And that's something that as PAs, when you made that comment, Amanda, how we want to test to make sure we give them an answer. And I'm like that. I'll biopsy it if I don't know what it is. If I can't give a patient, like I can't answer the question, what is it? Then I'm going to try to find out. And I think the diagnostic delay is that there's not a lot of coordination. People are in silos, or for whatever reason, insurance companies have a play in it. Lots of things. There's lots of factors, but I think if you practice in an area where you can have some colleagues that you can reach out to, then that might be one thing that you could do to help that situation.
Absolutely. Maggie? Anything?
I think the big answer is like the health system as a whole, right? Like we all have terrible wait times to get in for new patient visits. So I think, at the systemic level, increasing our new patient access, which I do think APPs do a really good job of in our specific subspecialties. I also think, as I had mentioned before, failure of patients and caregivers, and sometimes even providers, to identify what loss of mobility and weakness actually is for a patient. This isn't my story, but I had a colleague who saw a fourth opinion for actually neuropathy. And a woman came in and said, well, my legs are numb. And she told all these other providers her legs were numb. And, the provider said, okay, well, like, what does numbness mean to you? And she said, well, numbness means my legs are heavy. And suddenly, what should be a neuropathy consult turns into a consult for weakness. But she had spent all these other providers telling them that her legs were numb, so they had gone on a completely different direction. And that's to no fault of the patient. I mean, again, these symptoms are very hard to describe. And that patient did not have myositis. Unfortunately, she actually ended up having ALS. But that led to a huge delay in her diagnosis. And so I really think it takes a lot of clinical skill to really sit down with your patients and really get to know them and get to know what their symptoms are and how are they describing it. And where can we, as the experts, kind of parse out, okay, well, you're using this language, but what I'm seeing on my exam doesn't really match that. Or, you're telling me your legs are numb, but you actually just can't get up from a chair. And so I think knowing the difference and asking the patient the right questions so they can give us the information we need to evaluate them properly.
That is such valuable insight. Absolutely. So, Laura, talk to me about a case where multi-specialty collaboration perhaps changed the diagnosis, management, or outcome with a patient with myositis.
Um, there was a patient I saw, and it was interesting because she ended up seeing rheum, but she was almost borderline erythrodermic. So she looked just sunburned all over. And she was unwilling to, she had had a myositis panel when she came to see me. She ended up seeing rheum, and it was, I don't know if it was a confidence thing or what, but we ended up, he treated her with steroids, and but her presentation wasn't particular. Like, right, it wasn't usual from what I see. And in my differential, for somebody who looks pretty much erythrodermic, there are a lot of other conditions, lymphoma and whatnot, that can be overlapping. So I think it's really important to note when you're thinking across specialty that it basically doesn't always present how, there's a textbook look, and then there's these patients, and they just don't sometimes match up, right? So over the years, I've had several patients that nothing fits the textbook. I did have a young lady one time that fit the textbook. She was, her rash was textbook, but she did not have the myopathy. So she was amyopathic. Maybe she was just young and she was going to get, I don't know, but she was amyopathic. So I think that when you were talking, Maggie, I was thinking to myself, is there a question when because patients tell us this stuff all the time, or my legs are numb and tingly, and they throw that in there and they're like, oh, I have neuropathy. Well, is there a question that you could guide us on in the other specialties that would be like, oh, this is a giveaway that they need the workup? Like, is there a specific, like, is it getting up from a chair, getting up from the toilet seat or whatever, that we could channel patients to the right place?
No specific question. I think, as we all know, the physical exam starts when the patient comes back from the waiting room. So getting the patient from the waiting room and seeing them get up from the chair and seeing them walk can really prompt you to say, like, okay, I definitely need to ask some question about how are you getting around your house? Did you fall recently? And if so, what was the mechanism of that fall? Did your legs buckle beneath you? Did you trip over your foot? I don't think there's one specific question, but what I will say is if you have any suspicion for any kind of sensory deficit and or weakness, you need to do an exam, and you need to do a high quality exam of strength testing. And that's something that's very specific to my field. I actually work teaching the approach to the motor exam for the non-neurology provider, just so, people who don't work in our field can get at a good idea of like, what does high quality muscle testing look like? So I would say if you have any concern about someone's immobility or weakness or numbness, lay hands on them, do a good exam. And if you're not sure, send them my way.
Yeah, I think I'm going to be sending them your way because there's not that much time to do that. And the rest of our exam, a lot of times that's an after, people say that. But I think it is difficult if you're not in that field, to do that and do it correctly. It's just like if you were to come in my clinic and do a biopsy, I'd have to show you how, right? So,
or even a skin exam, same thing. I know and it's abnormal, but I don't always know what I'm looking at.
yeah.
Oh, this is like so helpful. I need both of you in my clinic with me. People show me rashes. I'm like, oh, it looks like a rash to me. It looks like someone should take a look at that, and it's kind of the same thing with patients that say I have numbness. I'm like, oh gosh, I don't know what to do with that. I check their reflex. I mean, I don't know. My neurologic exam has a lot to be desired. All right, I just have one more question for both of you. Maggie, give me a clinical pearl about myositis that you wish every clinician recognized earlier.
Myalgias and muscle pain are not always a sign of myositis. In fact, most myositis are pain-free, so painless loss of function. The other pearl would do that high quality physical exam. And then just one other final pearl, creatine kinase elevations. That's a snapshot in time. It's not a singular abnormal value. So if it is abnormal, it's a really good idea to trend it over time. Sometimes people can have abnormal CK if they're dehydrated or if they worked out really intensely. And so making sure that we are, using time as a diagnostic just as much as our other clinical tests and acumen.
That's awesome. I love those suggestions. Laura, do you have any?
Yeah. Hold their hand and look them in the eye. So if you hold their hand, you're looking at whether they have Gauthron's papules on the knuckle, not in between the knuckles, so on the knuckle. And you're also looking for capillaries, and you look them in the eye while you're holding their hand. And not only will they like you because you held their hand and they will bond with you, but then you're looking to see if they have a heliotrope rash. But it's just those subtle things when patients come in, put it in your differential. Put these things that you don't see that common, they're going to happen. They may not happen every day and they may not happen every year. But when they do happen, you need to recognize them. And that's the thing about derm in my field. I feel like if you don't know it and you've never seen it, you'll never see it. So you have to familiarize yourself. And even if you just every now and then glance at what a picture of it looks like and just keeping it front to mind that is in the differential. I think in the age of AI, maybe that'll even help that because people will start looking a little bit more because you can't find it if you don't know what it looks like.
I could not agree more. I mean, the thing I thought about first when you said hold their hand and look in their eyes was, the person that taught me most, the mentor that I is a second mom to me. Her name is Carol Beals. I was the first rheumatologist that I worked with. She said, just listen. All you have to do is listen. People will tell you exactly what's wrong with them. You just have to take the time to listen. So with that concludes this episode of RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. A huge thank you to Laura and Maggie for sharing their expertise and helping us unpack the complexities of multi-specialty care in myositis. Today's discussion highlights just how critical collaboration between all of our specialties is when we're recognizing evolving clinical features, navigating diagnostic uncertainty, and developing individual treatment strategies for patients living with myositis. Thank you to our listeners for joining us. We hope this conversation provided practical insights that you can bring directly into your practice. Be sure to subscribe to RhAPPcast so you never miss an episode, and visit our content room at rhap.org for additional educational resources, upcoming programs, and more information from the rheumatology community. For RhAPPcast, I'm Amanda Mixon. Thank you again for listening, and we will see you next time.